Pevny. I'm an orthopedic surgeon here in Aspen. I've been here about 19 years to the date, almost. When I came here, nobody performed total joints. I kind of started a total joint program a long time ago.
Can't hear you.
And it's evolved since then. Does this help?
Yeah.
So the total joint program, we're doing total joints here about 19 years ago now, and it's evolved to what you're going to hear about today. And
you got to keep the top close to
okay, so hopefully nobody else was kissing this recently. Yeah, that sounds better. Excuse me?
Only Michael Fox.
Only Michael Fox, okay. All right. So what I'd like to do first of all is thank the Aspen Club for hosting this and the Aspen Sports Institute here and all the physical therapists. It's a great turnout. Thank you for coming. What I'm going to talk about, when you give a talk, it's kind of like being on a first date or a blind date. So usually humor will kind of break the ice. And so this cartoon that I put up here to me isn't really that funny. It might be cute, but I thought it was very pertinent to the talk that I'm giving tonight. And this is really reality in about 15 or 20 years. What it is a robot and his children at a bedside on somebody the robot has operated on recently. So this is what we're going to talk about. In robotics in medicine is really the integration of artificial intelligence and traditional medicine. And it really is a new frontier in medicine. And it certainly isn't part of traditional medicine. I'll try to stay out of your way as much as I can. It's not really taught in med schools. It's still kind of out on the fringe. It's a really new concept and new technology. But I do think it's part of the normal evolution of medicine. For example, in the late 19th century, that's when anesthesia was invented. Okay? Prior to that, surgery was done without anesthesia, and it was really a crime. It was assault with a deadly weapon. That's a felony these days. So anesthesia came about, and we were able to do surgeries. They did big incisions, but everybody was dying from infections. So the next milestone in the evolution of medicine, and surgery in particular I'm talking about, is aseptic handling of tissue. So the Europeans taught us, hey, it'd be a good idea to wash your hands before surgery as well as after surgery. So we kind of figured that out, and people stopped dying from surgery. Then more recently, we transitioned from big incisions, which took a long time to recover from, to arthroscopic surgery and laparoscopic surgery. And that actually started about the time I was in medical school, about 30 years ago or so. And now the next frontier, I think, is robotic surgery. And so that's what we're going to talk about here tonight. And really, when we got interested in this is because we had a subset of patients that were a conundrum, really didn't have a good treatment option for them. And so we became interested in options that would help these individuals. And this talk, as it unfolds, you'll see how robotic technology helped us with that dilemma. So this is the typical patient. These are looking at the knees from the front. So this would be the left knee if I'm standing in front of somebody. And you can see how there's narrowing between the femur and the tibia. This might look familiar to many of you guys in here. This is a normal knee. So what do we do with this individual? They have pain, they failed non-operative treatment, they've done physical therapy here at the club, they couldn't help them, which rarely happens. So what do we do to brace them? An brace is a pretty good option because you can unload that side, but it's not definitive treatment. What about an arthroscope? Well, an arthroscope we know does not cure arthritis. Now, if somebody has arthritis, the typical symptoms are that they slowly progress. An arthroscope is not going to help that alone and realign it, but that's kind of a barbaric operation these days. We still do them, but very rarely. But it's only gives you relief for about 5 to 7 years, and then you have to do something else. And a total knee replacement after an osteotomy, the results aren't as good as a primary total knee. So that's not a great option. Well, a partial knee seems like a great option to me. You just replace the part of the knee that's diseased. But there's been some problems with it. A lot of surgeons don't want to do it because it really does not have a great track record in the literature, and the results have been very unpredictable. Many surgeons would do a total knee because that'll get rid of the problem. But a total knee in this situation may be overkill. You might not need a total knee. So we'll see how we got to the robotic surgery for that individual. Now, just a little background. Robot is a Czech word. which I found very exciting since I am from Czechoslovakia. If you guys did not know that, you probably figured that out by my accent already. But this was in 1921, and this was by a Czech playwright who came up with the word. It means hard work or labor. And then robotics is a branch of technology that deals with the design, construction, operation, and application of robots. And this was introduced to the world by a guy by the name of Isaac Asimov, who maybe you guys have heard of. He was one of the premier hard science fiction writers of the 20th century. He wrote a lot of books. I actually read a couple, and they were difficult to get through because they were so scientific. So this was 20 years later, 1941. And he came up with these 3 laws of robotics, which to me are like the Hippocratic Oath of robotics. 1, a robot should not harm a human. 2, a robot can take orders from a human as long as it doesn't violate law number 1. And number 3, robots should protect their own existence. So those are the 3 laws of robotics. And you can see this was a picture that someone drew of him with symbols on that chair of his life works. And you can see that front and foremost are 2 robotic figures right there. So he was very instrumental in robotics. And it's interesting to me that a writer and a playwright came up with this idea. You know, in my mind, I always thought of some mad scientist in a dungeon coming up with an idea of a robot. But it's really people that have great imagination and obviously a lot of intellect as well that came up with this concept. Now, the first programmable robot was the Unimate. It came out in 1961, and this was used by General Motors to lift and stack heavy pieces of metal, obviously an activity that can be very dangerous to a human. Now, domestically, you can use robots as well. This is a robot that will actually vacuum your house. So for all the gentlemen, it might be a nice birthday present or Mother's Day gift next year. And also in the military, really uses robotics more than anybody. They use it, again, where it's harmful for humans, such as defusing bombs or landmines. And pretty soon when we do go to war, such as our recent wars in Iraq and Afghanistan, I wouldn't be surprised if in the next 10, 15 years we actually send robots over there rather than humans. And also it's part of our culture. You guys remember the Terminator movies? You know, obviously the writer of those movies did not obey or know Asimov's 3 laws of robotics, because in that movie the robots were trying to kill the humans. But it is part of our culture. My favorite robots are the fembots. You guys remember the fembots? They're from the Austin Powers movies. They have the ability to shoot bullets from what you can see there. Now Google, you guys have probably heard of this driverless vehicle. And this is really just another form of a robotic. Google has assembled the largest artificial intelligence laboratory in the world. They've actually bought up most robotic companies that they feel are significant in the world, and they're going to be the leaders in robotic technology in the future moving forward. And I thought initially this was kind of gimmicky, you know, but about 35,000 individuals die a year in car accidents in the United States. And then I started thinking about it. You have a driverless car. Right now, when you have navigation in your car, it's all Google technology that tells you where to go. And if you have a driverless car, they can't drive drunk, they don't get tired, they can't text and drive at the same time. So, you know, there is some validity to it. And the other thing that Google has is this Google Glass. I don't know if you guys have seen it or heard of it. And it's really just a little computer on these eyeglasses. And what's going on, or what you can do in surgery with this, is that as a surgeon, you could wear this, and really not many people are doing this at all. But what you can do is you can pull up, if you're operating on somebody and you want to see an X-ray or a CT scan, or you need a lab value, it'll show it up to you on glasses. You could actually videotape the surgery, and online, that patient's significant other could be watching that surgery live on a smartphone or a computer. Or where it is being utilized now, but only by a small number of surgeons, is for educational purposes. There's an Indian foot and ankle surgeon at Duke that uses Google Glass to stream his surgeries online, all HIPAA compliant, to India to teach the Indian doctors how to do that surgery. So I think we'll see more of that in the future. Now, the first medical robot was the Heartthrob. This was in 1983 in Vancouver, British Columbia, and it was a arthroscope. It was a robot that did arthroscopic surgery. And what we found out, What we found out was that robots really don't do arthroscopic surgery nearly as well as humans, so that didn't go anywhere. I have a lot in common with Brad Pitt, actually. Besides our bodies, we do share the same birth date and birth year, which we both have beautiful lives, so we have a lot in common. So now we'll talk about how robots are utilized in medicine. The one on the top left, and there's various applications, is used mainly in the Far East. It's made by Panasonic. It's called the Hospi, and what it does, it's a transport robot. So if you're in surgery and you need some medication, these are programmed to go to the pharmacy, get the medicines, and bring them back to the surgery room. Now you can see on the top right that prosthetic arm robotic technology is heavy into prosthetics. And these days, some of these prosthetics aren't very sensitive enough that they can hold the light bulb and not crush it, and also durable enough to use power equipment. So the technology there is amazing. The one on the bottom left is called the Da Vinci, and the one on the right is called the MAKOplasty, which we'll talk a little bit more about here. Now the Da Vinci robot and it's used mainly in general surgery, urology, cardiac surgery. I don't have any personal experience being an orthopedic surgeon using it, but it's used worldwide. By 2012, there are about 200,000 cases. There's 2,000 robots sold. They're about $2 million each, and it costs about $200,000 to $300,000 a year to maintain the hardware and the software. You can see on the bottom left how it's used. What happens actually is that the surgeon is at a console, and his hand movements then allow these 4 to 5 robotic arms that look like the one on the top right to perform the surgery. And so even if a surgeon has a tremor, the robot can actually take the tremor out, okay? And so that the feeling is that you could work through smaller spaces more precisely. Having said that, you know, a lot of surgeons still don't use it because one, it is very expensive, and two, there's no long-term studies that show that it's any more effective than typical laparoscopic surgery. And this is the MAKOplasty, which we'll talk a little bit more about here. And I'm going to regress and go back to a little basic science and anatomy 101. By going over this, the rest of this talk will make a lot more sense to you. And this is looking at a right knee, and with the kneecap off. And the knee is made up of 4 bones: the kneecap, which sits up here, which isn't here, the femur, the tibia, and the fibula. There's 4 major ligaments: the medial and lateral collaterals, and the 2 cruciates on the inside. And there's 2 types of cartilage. One is the meniscal cartilage, which is the shock absorber. You have 2 of them, medial and lateral. It helps distribute stress evenly. Main function is to protect the smooth cartilage, what we call hyaline or articular cartilage. When you get arthritis, by definition, what that is when this smooth cartilage breaks down. And the most important concept of this talk is that the knee has 3 compartments. It has a medial or inside, lateral or outside, and then the patellofemoral, the kneecap, and the groove that it rides in. And so this is what a normal knee looks like if you put the arthroscope in. You can see the cartilage. On the top is the femur, on the bottom is the tibia, and in the middle is the meniscus. And the articular cartilage is very efficient as a bearing surface. And if you look at ice on the left, the number below is what's called the coefficient of friction that tells us how efficient a material is as a bearing surface. And articular cartilage is over 4 times as efficient as ice on ice, a normal articular cartilage, as a bearing surface. And that video on the right just shows you the glistening surface and how it glides, even though the video is not coming across very well. So this is what a knee looks like when it starts to wear out. You get erosion of the cartilage, and really the holy grail of what I do, or what we do as orthopedic surgeons, is to prevent this from happening. Or if it does happen, how we can restore it to a natural state. If somebody figures that out, they're going to make a lot of people happy and become very rich at the same time. And this is what it looks like arthroscopically. You can see how that surface is not nearly as smooth as it was in the normal knee. Now, arthritis is a big deal. It's getting bigger. It's the leading cause of disability in the U.S. It affects over 15 million people. And there's greater direct and indirect cost of greater than $100 billion a year annually just treating and trying to prevent arthritis in the United States. And there's various causes of it. Idiopathic is if it just happens. There might be a family history. but there's been no trauma, no previous surgery. Maybe someone has some malalignment, or genetically their articular cartilage is soft and breaks down, but that's what we call idiopathic. It just occurs. What we see around here a lot is traumatic or post-traumatic arthritis. This is a very common MRI that we see of a tibial plateau fracture. Someone skiing, for example, the femur comes down and hits the tibia and kind of crushes it and pushes it down. And what it looks like, and a lot of these will fix arthroscopically, the articular cartilage will look like this. You can see where this is normal cartilage to the right, and then this is where it's been pushed down. So, but besides the macroscopic trauma of this being pushed down, we really don't know what happens microscopically to the cartilage cells if they die or get killed, or the extracellular matrix. But a situation like this can certainly lead to post-traumatic arthritis. And this is what it looks like when we push it back up, but you can see that it's certainly not normal. Now, if you lose a lot of your meniscus, as we talked about, it helps distribute stress. Then there's going to be more stress on the articular cartilage, and that can lead to arthritis as well. And some people can have a direct injury to the cartilage, a focal injury, and that's what this demonstrates, and that's what we call a microfracture, where we poke holes in it. But despite that, that'll heal in scar tissue, not normal cartilage. And sometimes we take plugs of cartilage and bone from another part of the knee and transfer it to a focal defect. But these are areas that are isolated, the cartilage around it is normal. And then if you have an ACL tear, that can lead to instability, so you get a change in the physical environment as well as the chemical environment in the knee that can lead to arthritis. And certainly if you have inflammatory arthritis such as rheumatoid, lupus, psoriatic, whatever, that can cause arthritis. And if someone has an infection, say for example after a knee arthroscopy, that can lead to arthritis as well, just because of all the cytokines and inflammatory cells that break down the cartilage. Now we have various treatment options. We always treat people non-operatively. I'm not going to go into that so much. The only thing I will say is where it says injections, one of the hot topics now in treating arthritis is not only cortisone injections and what we call hyaluronic acid, but also platelet cell injections and stem cell injections as well. If anybody has questions about that, I'd be happy to answer those after the talk. Now, surgery can be categorized into disease-modifying, where we can treat the symptoms for a while, or curative. And the curatives are either a uni, which means one, or bi-two replacement, where you replace either one or two compartments. So that's called collectively a partial knee replacement if you do that, or certainly a total knee replacement is going to cure your arthritis as well. Now this is an interesting slide. This shows you how many total knees and total hips are done in the United States. And this only goes up to 2010. And I would say this year there's probably going to be close to 1 million total knees done in the United States. That's a lot of total knees. And it's estimated that in the next 15 to 20 years, that number is going to increase by 700%. Okay? So there's going to be an epidemic of total knees done. And there's several reasons for it. One is because total knees do exceptionally well. The literature supports it. This was a study, it wasn't a long-term study, it was only 7 years, where they took a lot of knees, 25,000 from Norway and 56,000 from the Kaiser Permanente healthcare system. And about 95 to 96% of these were still doing well at 7 years. So total knees do well. But the other reason we're doing more and more total knees, and I must say that number, which is important, of 1 million total knees done, less than 10% of those are partial knees. So over 90% of those are still total and not partials. But another reason we're doing so many is that people are living longer. You know, the average life expectancy today is close to 80. And in 15 or 20 years, it's going to be close to 100. And a very interesting statistic is that 2/3 of all 65-year-olds in the history of the world are alive today. So there's a lot of old people, you know, so that's why we're doing more and more total knees. And another way to look at it is there's the 1-20-50 rule. So for every 20-year-old, there's 20 50-year-olds. So the bottom line is our population is aging. And so if you live longer, what happens? You know, if you have a vacuum cleaner for a long time, it's going to wear out, right? Same things happen to our joints for a reason. Now, not only are we getting older, but we're staying active as we get older. And this is one of my favorite slides. I don't know if you guys recognize this gentleman. His name was Falja Singh. He was the first 100-year-old to finish a marathon. And he did several marathons. And and he didn't start running until he was in his 80s. And it's actually a very fascinating story how he got into running. If you're interested, we have it like on ESPN.com. But he's run several. I don't think he runs anymore. I do think he is still alive. So not only are we getting older, but we're staying active. So all that repetitive trauma is not good for our joints. The other problem in the United States, not so much here in this room, in this community, is obesity. You know, the heavier we are, the more stress we put on our joints. And this graph shows where the United States is in comparison to other industrialized countries in the rate of obesity. And, you know, we think everybody's about there. I think recently Mexico actually passed us. Of all other countries, America in general is the fattest country in the world. Now, you guys may not remember Sir Isaac Newton, but physics is one of my favorite subjects. And it's pertinent to obesity because he's the guy that taught us about inertia and that force equals mass times acceleration. But what's pertinent to this is that his third law was for every action, there's an equal and opposite reaction. And so when it comes to obesity and joints, what it is ground reaction force. So every time we take a step, the force that we're putting into the ground is coming right back at us. And actually, the reason that weight loss is so important in treating people with painful joints is that for every pound loss off your weight, it's 10 pounds off your knees. So there's also a fourth law that I can't leave without saying. This law that I came up with, that too much of this will lead to that. So that's the fourth law. So if we have an x-ray like this is a normal x-ray on the left and an arthritic knee on the right. The treatment is easy. We do a total knee and people actually do generally very well. But our conundrum is when we have this situation where it's worn out on one side, but you have normal cartilage on the other. And again, the intuitive thing to do would be to do a partial knee replacement on this so that you don't violate the normal compartments of the knee. And there's many advantages to doing a partial. It's less invasive. You do it through a smaller incision. You retain all the ligaments. A very important concept today is that when you do a total knee replacement, you always take out the ACL, even if it's perfectly normal. You always take it out. And about 50% of those million done, the surgeons take out the PCL. And the design of the components give you that stability. But in a partial knee, you don't take out any ligaments, so you retain the normal movement or kinematics of the knee. So there's certainly advantage to that because you're going to have a more normal gait. With a partial knee, you're going to preserve more bone. It's pretty easy to convert a partial knee to a total knee. The results are actually very good on that. There's less blood loss with a partial knee, faster recovery, and greater patient satisfaction, you would think, right? So that all sounds great. But when things sound too good, there's always a but, right? So the but here is that there's been a mixed reception by orthopedists in the past, okay? And it's because it's technically more difficult. You're working through a small incision. You don't see as well. There's a longer learning curve. And it's much more subjective. The way a standard partial knee is done, we as surgeons look at it and we look at the alignment and we think, yeah, that looks pretty good. You know, so it's very subjective. Even though we have good instruments, there's still a lot of inherent error when there's subjectivity involved. So it's very less forgiving. And if you get that alignment off, even by a few degrees, it's going to fail. So because of that, we've had poor results, and because of that, it's been a very underutilized procedure. And this kind of reaffirms that point. This was an interesting study where they looked at about 100 knees that they did total knees on, and they went back retrospectively and looked at the pre-op x-rays and MRIs. They looked at their exam, and they looked at what the knee looked like in surgery. And what they found out is that of these 97 total knees, 21% of them could have had a partial knee. So that tells you two things. One, a partial knee is underutilized, and two, surgeons generally in the past have had a lot more confidence in doing a total knee, even when a partial knee was an option. And another reason we didn't do them is because a study like this that had 90% complications at 1 year and almost 50% at 5 years. So historically, because of the lack of accuracy and the subjectivity, surgeons kind of shied away from partial knees. Then in 2009, a study came out, and it was really more a conceptual study. It wasn't a clinical study by Martin Roche and Michael Condit. And what they described was this minimally invasive robotic arm partial knee replacement that they felt was more accurate, reproducible, and would improve outcomes. So that's pretty exciting. And they used this MAKOplasty robot. And so the way they described this MAKOplasty was that it was a surgeon-controlled robot. So the surgeon is scrubbed into surgery that combines computer imaging, meaning that what you do preoperatively, you get a CT scan of the extremity. You can look at it in 3 dimensions. You can determine exactly what size component you're going to put in before you cut the patient. You can determine exactly where you're putting it on the bone before you cut the patient. And you can move the knee through range of motion to make sure that it tracks just like you want to. So that's what the MAKOplasty concept is. And it's for partial knee replacements, either 1 or 2 compartments. You can do a total hip with it. One of my partners, Dr. Harris, does our hips with it. And he's had really good results with his hip replacements. And again, you retain the ligaments, minimal bone resection, accurate and reproducible, and better results, at least theoretically. So who's the best candidate for this? Again, you have to have only 1 or 2 compartments. So someone that has, for example, inflammatory arthropathy, like rheumatoid, it's going to affect the whole knee. Those type of individuals are not candidates for partial knee replacements. And you have to have good range of motion. You can't have a stiff knee because you can't correct that with a partial. You can with a total. You have to have normal stability. You don't have to have normal stability with a total knee because we're going to take out those ligaments anyway. And you have to have minimal deformity and not be obese. So out of these guys, this guy is the best candidate. And so this is an important slide because this kind of shows what this MAKOplasty or robotic partial knee, the niche that it has filled. On the left, you see a little cartilage injury that's very focal and small, and the rest of the knee looks good. This can be addressed with an arthroscopy, either with a microfracture, what we call a Oaks type of procedure. And if you have the other extreme where the whole knee is worn out, you're going to do a total knee. But it's this individual in the middle that we see a lot of, where only part of the knee is worn out, where you can do a MAKOplasty and avoid total knee arthroplasty and the added trauma from that. So again, we come back to this patient that I showed you initially. There was our dilemma that has the joint space narrowing, medial compartment of the left knee. So this is what we do. That was an actual patient x-ray, and this is an actual CT scan. And what we do with the CT scan, this is the tibia, the lower bone. So what we could do is we could put a component on the CT scan right where we want it, where it needs to go. And we're able to adjust rotation. Varus means this alignment. We're able to align what's called the slope. And then we're able to look at it from above to make sure that it's the right size, that there's no overhang, that it's not too small. So we're able to determine this both on the tibia and on the femur preoperatively. And this is just a picture of the femur looking at those same things. And this is just a little, I don't know, yeah, this video works. This is just a little animation showing how we put the components in the different sizes. We're able to rotate the bones, look at them in 3 dimensions, and get them exactly where we want them. And then the other thing we do at the time of surgery, once we get our components preoperatively, at the time of surgery, we place the knee through a range of motion, and then the software will tell us, based on this graph, if based on our preoperative planning, if it's too loose, like it is here, so we can adjust on the CT scan our components. We can move it down, we can move it back to get this just right. So it's not too tight and not too loose. So we're able to determine that at the time of surgery. And then we're able to put the knee through a range of motion, and it tells us if the femur is tracking appropriately on the tibia. So it's pretty amazing software. And so then once we get all that information, we give it to the robot. And we give it to the robot by this optical technology. It's infrared signals. So these are the brains of the robot. This is the cutting arm that the surgeon controls. And this is an array where it receives the information via the infrared lights. And so this is just showing how the surgeon can control this arm. And really the only working part of the robot is this little 6mm bird that you see here at the bottom. So once we get all our information, we give it to the robot, and this is what the surgeon looks at, is that computer screen. And you can see this is where the infrared signals come and go to convey information to and from the robot and the surgical field. And so this is us just demonstrating this on a sawbones. So this is one of our old fellows, Dan Lee. And you can see what he's doing is he's not even looking at the knee. He's looking up here at the screen. And you can see, I'll show you on the next slide, there's these arrays. We put pins in the femur and tibia, and we put these arrays and we have these little metal locators on the tibia and on the femur, so that the robot knows exactly where the bone is. And it gets locked in, meaning that once we get all the information locked into the robot, if I move the patient on the hospital bed in the OR, the robot will actually follow that patient's knee. That's how locked in it gets to the knee. So this next slide just shows you the arrays that we put onto the tibia, below femur. And then this is a video, and you hear the sound. So what we're doing, it's like a video game. So what we're trying to do is the bone that we want to resect based on our pre-operative planning is the green. So what we're doing is we're looking up at the video, and we're actually just kind of getting rid of the green, so it's really like a video game almost. But you have several sensory, tactile, visual, and auditory signals that help you throughout. You hear the noise, so you know that you're cutting. And when you get to the part of the bone that's out on the edges, what happens is it'll start beeping, telling you that, hey, you're getting close to the edge where you don't want to cut. You have a visual sensory signal because we're looking there. When we get rid of all the green, we know that we're finished. And then there's also a tactile feedback mechanism, is that when we get close to the edges, we'll get resistance, and the robot will not let us cut anymore. So if something happens to me and I'm not paying attention, you can see where it's red there. The red means that I've gone too deep, but that's 0.5 millimeter too deep. If I go any deeper than that, the robot shuts off. So it won't let me cut out of that field that we predetermined. So it's got a lot of fail-safe mechanisms. And this is just a little animation showing you again how we do it. And we're just looking on the green, and we're cutting away the bone. And you can see that we're cutting away minimal bone. We're just getting rid of the bad bone and bad cartilage. We're not taking any significant structural bone. And this is us cutting the femur. And if we're going to do 2 compartments, we would do this. Otherwise, if we just do 1 compartment, the medial, we wouldn't deal with this part, which is the groove that we will capitalize in. So this is showing a bicompartmental replacement. So minimal bone, we don't take out any ligaments. The prostheses fit perfectly into the cut bone. And the knee has normal kinematics. Moves very efficiently, restoring natural motion.
Dr. Pevny, what's the material made out of?
The material is made out of cobalt chrome is the femur, and the tibia. Most total knees are made out of cobalt chrome. It's a very hard metal. Titanium is a softer metal. In this system, the femur is cobalt chrome. The tibia is actually titanium. So it's a titanium. It kind of matches the physical properties of bone more than the hard ones. And then we use what's called ultra-high molecular weight polyethylene, which really just means it's a hard durable plastic that snaps into the tibia.
Good answer. Are the prostheses customized to the patient?
No, the cutting is customized to the patient, but the prostheses will come in different sizes, 1 through 6.
I'm going to see you Monday, so I'm going to save a lot of questions. So I'm going to ask you one now. What form does the biggest potential failure of this procedure take? In other words, if it doesn't work, how does that manifest itself?
If you have a complications in the procedure?
Yeah.
Well, to me, when you do a partial knee replacement, probably the most important thing is proper patient selection to begin with. Meaning you could do a beautiful operation, technically very sound, but if it's somebody that has arthritis in other parts of the knee, they're still going to have pain. So one potential complication is that someone could still have pain from arthritis in other parts of the knee. And you know, that's a problem sometimes, because you have a technology and you want to use it. I'm not talking about myself somewhat, but there are surgeons that will use it because they have the technology, but you have to do it on the right individual. The other thing is, just like any other operations, when you cut skin, there's a chance of infection. There's a chance that it can loosen. You know,
That's a physical breakdown.
Physical breakdown between the bone, the cement that we use like a grout, and then the metal. So it can loosen, you can get infected. But if it does fail, you can convert these rather easily because of the minimal bone resection to a total knee replacement. But you want to do the right thing for the right patient. So not everybody's a candidate. You know, some people will probably be better off with a total knee. And the way it manifests to the patient is persistent pain and swelling. Just gonna think about it. So this is surgery showing that same patient. We looked at the x-rays and the CT scan. And what I'm doing here is I'm holding up a probe at the computer. I put the tip of the burr on this probe, and that's how we calibrate everything once we decide where the components are going. So we make an incision first, expose the part of the knee that we're going to replace. I put on the arrays on the femur and the tibia that you see there, and then we calibrate the robot. And then you can see I'm not looking at the knee so much. My system looks at the knee generally. He's not there, just to make sure that all the soft tissue is out of the way. But I'm looking at the computer, cutting the bone. And then these are the components that you asked about. So the one on the right goes on the femur, the one in the middle is the tibia, which is the titanium, and on the left is the plastic that snaps into the tibia. So the robot will cut the bone, but the surgeon still has to put the cement in and put the prosthesis in. The robot doesn't handle it and put it in. So this is a knee, right knee, looking at the medial and inside part of the knee. And you can see the femur, the shiny one on top, and the tibia below it. That's what it looks like.
How long is it?
Yeah, you know, I always say you can't fix what you can't see. It's a smaller incision than a total knee, but you still have to, the size of the components, you still have to make a decision about who you feel comfortable with. I'm sorry, what was the question?
I was going to say, how long does the average procedure take?
An hour and a half. Yeah, from the time we cut skin to when everything's closed. Like I hear a lot of people come in and had surgeries elsewhere, and they say, "Yeah, my surgeon did it totally in 30 minutes." Well, that's the amount of time he spent in the OR. You know, he had a PA or a fellow or somebody opening the knee. He came in, put in the components, he left, and everything was closed. So, you know, it takes about 15, 20 minutes. You know, close the knee, doing your exposure, it takes about 10, 15 minutes as well.
Dr. Pevny, the indexing device, you actually screw that into the femur, or how does that attach?
Yeah, they're two 5mm pins, and we do them through small little poke holes, incisions, and we drill it into the femur. And there's two of them.
One on the tibia.
Two in the tibia as well. And that's what holds those.
That just
arrays.
indexes the robot.
Yeah. There's minimal morbidity from that. People usually don't complain of pain or have any issues with post-op. And so this is what it looks like before, and this is what it looks like after. And this was one of the earlier cases we did. We've been doing it about 2 years now. So our incisions, as we get more comfortable, or have gotten comfortable, are actually smaller than they were. And this is that patient 6 weeks post-op. This is the range of motion, 6 weeks. So they do pretty well. They recover much quicker than a total knee replacement generally. So that all sounds great, but what surgeons really want to know about, and patients too actually, that they don't ask this question a lot, is how does the robotic partial knee do head-to-head with a traditional one, which I showed you earlier, didn't do great. And there are some good studies out now, and when there's new technology, it always takes a while to get good literature because you don't have a follow-up. But now, we've been doing it long enough, we're getting some follow-up. And this was a good study that looked at, it was a prospective randomized controlled trial, looked at a manual traditional Oxford partial versus the MAKO. They had quite a bit of patients, blind assessors, so it was a good study. And the MAKO was more accurate based on the CT scan, and clinically they did better. They had better knee scores, reduced pain, less hospital time. So that's a good study to support the robotic technology. It's a knee score. There's about 20 knee scores out there that are used for research purposes post-operatively. Usually they're both subjective and objective questionnaires and measuring range of motion straight. So, and this was another study that showed that using the robotic versus the standard partial knee, when they looked at post-op radiographs, all of the robotic patients had alignment within 2 degrees of pre-op plan, where only 40% of the conventional group had no alignment. And as I said earlier, alignment is the key. You got to get your alignment right or things are going to fail. And this was just looking at, and this is very short term, 2 years, but they looked at the MAKO partial knees versus the Swedish and Australian registry for traditional partial knees. And in 2 years, only 1% of the MAKOs failed, whereas 4.5 and 4.8 of the traditionals failed. So all this literature, which is good solid literature does support the robot for partial knee replacements.
Which is the failure, was the components that you have, or the patient that tore out?
Both. They either failed, came loose, or they had to be revised to a total knee. So there are some limitations to this, as there always are. One is financial barriers, and not so much for the patient. We charge no different for a robotic partial knee than we do a traditional partial knee. So I don't make any more money. But it's very expensive for the institutions to buy. The robots cost over $1 million. They can cost several $100,000 in a year or two just to maintain the hardware and software. So institutions need to determine if it makes financial sense, and it doesn't for a lot of institutions. And there have been some safety issues in the past, and this was more so in Germany. They used what's called an autonomous robot, where the surgeon would make the incision. The robot would actually go in, it was pre-programmed, and do a total hip replacement without the surgeon scrubbing in. And it was called this RoboDoc, and they had problems with bleeding, increased operative time, nerve injuries. There was a lot of litigation, so they discontinued that robot. And again, there's a lack of long-term evidence studies. I showed you some studies, but they're not 10, 15 years down the road. That's really what you're going to see. So in summary, I would say that robots are a benefit to society, industry, certainly the military and the medicine. Medical robotics is dynamic and evolving. And I think it's one of the new frontiers, and it's part of the normal evolution of medicine, especially on the surgical side. And the MAKO, at least for us, has filled the niche of that mid-stage arthritis. And robotics will revolutionize how we do orthopedic surgery in the future. They're working right now on doing a total knee replacement with the robot. It's not out yet, but it's kind of in the developmental stages. But that, the advantage of that is that they will also, it'll be a total knee where you retain the ligaments. So that'd be great if we can maintain those kinematics. And they're already coming out with a total shoulder, one of the companies, for robotics. And ultimately, I think in sports medicine, we'll be using it as well. But right now in orthopedics, really the only robotic surgery is for partial knee replacements and total hips. So thanks for your attention. I'd be happy to answer any more questions.
Is a laser used for all the
A what? A laser? No, it's a burr. So basically, it's a burr that you can either control with a handheld device, or I like to use the foot device. It causes it to spin, and it basically burrs the bone away. So when we're looking at the computer and trying to get rid of all that green, which is the bad bone, the burr is getting rid of that. So it's a burr that cuts it, and there's a fluid source that goes in, so it doesn't overheat, because you don't want to overheat the bone and kill the good bone cells that are adjacent to the bone you're dissecting. It has suction to the burr. So it's a burr. It's not a laser device.
Did the ACL reconstruction
Yes. There's actually some individuals that have an x-ray like the one I showed and have an unstable knee. So we'll actually, you can do an ACL reconstruction each staged, and then do it, stabilize the knee, come and do an ankle, or do it at the same time. But yeah, I've done them on several patients that have had ACLs, so that's not a contraindication to it at all.
How many do you think you do a week?
I might not do any of it. We've been doing it for 2 years, and we're getting close to 100. The question was if you have an ACL reconstruction, if you can still have a MAKOplasty. And the answer is yes.
And what do you have to do to sign up your candidate?
It's a combination of things. It's obviously getting good history from the patient to see if they're ready for it, make sure they've exhausted all non-operative treatment. 2 is a good physical exam to make sure that you have good stability, good alignment, good range of motion, to see exactly where you hurt. And 3 are the imaging studies, which would be either the x-rays, and sometimes x-rays are actually better than an MRI for looking at alignment and arthritis, because x-rays we use standing, whereas an MRI you use supine, so it really doesn't tell you anything about alignment. Sometimes you can have normal looking x-rays if someone's lying down, and once you're standing up and you're waiting on the films, it can really show malalignment and joint space narrowing. So then the imaging study. So it's a combination of the history, the physical exam, and the imaging. And then we determine if we're a candidate for that or some treatment. Yes.
What happens when these patients go through the X-ray machine at an airport? Does it set it off?
You know, it's hit and miss, I think.
Question.
Does it go off in an airport if you go through security? Does it go off? And it's hit and miss. I have some patients that have no problems. Other people do. We do have these cards that, I don't even know if we give them out anymore, but that said you have a total joint in your body because they don't care. You know, I mean, if you're going to beep, they're going to do your lawn and all that. So.
Exactly.
But not everybody does. I have some patients that they're done.
I get the question a lot, what's the longevity of these prostheses?
Yeah, and I don't know the answer to that. I'll know that answer when I'm retired, hopefully, because we'll have long-term data on it. But right now, we just have short-term data, and the line looks good. Theoretically, it makes sense that they would last longer than traditional ones because we know we're going to need alignment right. And so if you pick the right patient and you get the alignment right, I would say a partial knee replacement should last 20 years. You know, some of the companies have done studies in their labs where they've simulated daily motion. So it's not like being on uneven surfaces, but in a lab, a lot of these materials last 30 years. But it's a simulated activity. The question is, where do we do it? Only in Aspen. When we got this robot 2 years ago, we were only the second one in the state to get it. And I think there's a couple more now. There's one in Lone Tree, one in Boulder. I'm not sure where else. I don't think there's one in New Mexico or Wyoming. I think there's one maybe in Utah and Salt Lake. So there's not a lot of them. I mean, still, you know, another take-home message is this is not mainstream. Not everybody's doing it. And again, the reason not everybody's doing it is because I think of the cost and the hospital cost. You know, so, but I think it's great technology. I mean, certainly, just like giving this talk is to educate you guys. It's a great marketing tool, you know, but it's not gimmicky. It's the real deal. I've had one of these get infected, and our infection rate here is, I'm trying to think of a number, it's probably about 1%. The national average, I think, is about 4% or 2%. Do you know, Judy? 3%, so I was right on there. It's about 3%. So our infection rate is lower than the national average. So one reason is it's a small hospital. We don't have a lot of sick people, not a lot of bad germs. We wear these space suits that you saw me in. You know, we go the extra yard to keep things as sterile as possible, as we should. But it can happen. When an infection happens, we don't know why. You know, it always comes down to the surgeon, but there's so many steps involved. But they do occur.
What's the general attitude of the orthopedic community to this procedure? Is it positive? Is it neutral? Is it negative? Does the orthopedic community like the evolution of this thing, or are they uncertain at this point?
You know,
people like Spellman and Bale, for example. What would he think about this?
He wouldn't have an opinion because he doesn't do this type of surgery, so I don't think he has an opinion. Most orthopedists aren't familiar with the technology. A lot of them aren't. Even ones that do partial knees and total knees. Of the ones that do this, the surgeons love it. I mean, there is a little learning curve, but we practice and we make sure we're comfortable doing it before we do it on real patients. But you know, it really does work. So the docs that use it love it. And it's just like anything else. If you don't use it, you think your way is better. But the literature has proven that the old way is not working. And the literature has proved that the old way doesn't work. You know? So, and there's no bad data in regard to this. So, you know, I think people that are familiar with it and use it love it. If it's anything that you're not familiar with, you know, you're going to say, well, I do it better. That's one problem with medicine, is that surgeons get set in the ways they do things. And they're very reluctant to change. You know, because you get comfortable doing a procedure one way, and it's a big deal when you have to start changing things. But, you know, and I'll do that. I'll change if I think it's better for patients. And this is one example.
On
But yeah, the recovery is quicker with a partial versus a full. We don't brace these people. We put them in a soft dressing. We encourage movement the day of surgery. We get the patients up the day of surgery. Usually they'll spend one night in the hospital. I bet in the next year we'll be doing them as outpatients. I kind of like having them spend one night because we keep them on antibiotics for 24 hours, so for the infection rate, I kind of like that idea. Most people are off the crutches after a week or two. They're getting therapy after a few days, and it's probably about 4 months before we're doing everything. You know, and I say 4 months, I mean, I've had patients that are skiing in 6 weeks. Everybody's different. You know, it all depends on the motion, strength, and the confidence level. But because the components that are in there are as solid as they're going to be when you leave the door. Because the cement is hard within about 10 to 15 minutes. So once you leave, your components aren't going anywhere. The recovery just has to do with the soft tissues, the swelling. Having said that, we've gotten so much better in the last year, even in the last 6 months, at controlling post-op swelling and pain. That used to be a big deal with total knees, and it still is to a certain degree. And partials would be the post-op pain. I mean, knee replacements just hurt more than shoulders or hips. But based on medications that we give right before surgery, medications that we inject into the knee at surgery, and our post-op pain management, people tolerate it much, much better. So, and with these, they're pretty comfortable. I mean, even after a few days, people get around pretty well.
They can walk around in a couple of weeks.
Yeah. Yes.
Yeah, I have a friend in LA, and he hasn't been able to ski for 6 or 8 years. He's been in so much pain. And he's been talking to some doctors out there. He needs a knee replacement. But they told him he would never ski again after a knee replacement. Now, who sets your criteria for their problem? Stryker, the manufacturers? Or just, does it depend on whether you live in an athletic area of the country or what?
Usually the surgeon will set those
The
parameters.
surgeon,
The American Academy of Orthopedic Surgeons comes up with guidelines based on the world literature, and some of those guidelines are on total knees of what activities are recommended or not recommended. You know, and skiing is actually not recommended. It's somewhere in between. It might be closer than not recommended, but you know, around here, I wouldn't be doing total knees if I told people they couldn't ski. But having said that, we recently did a study looking at our total knees. And what we looked at was to see if skiing affected the longevity of the total knee, if there was earlier failure rate, could patients get back to skiing the same level they did preoperatively, and patients did well. We really didn't see a big failure rate. You know?
any given day, there's going to be 50 people on Aspen Mountain with a joint replacement.
There's probably 200 or 300 of them. The problem is that, you know, if you live in the Midwest, you live on the West Coast, a lot of those surgeons just aren't comfortable telling that patient they can go back and ski. One, because the literature is somewhat fuzzy and gray, you know, so the safe thing is to say no, because the last thing you want to do is say, tell someone they can do an activity and they go out and break their femur or MAKOplasty or something like that, which can't happen. So I think it's just not being familiar with that, and the literature's not clear cut. But I can tell you on our literature, when we looked it up, one of our fellows this year actually did the study, so it's brand new data. They do well, they ski, and there's really no complication for skiing with a total knee.
Is there any significant difference in efficacy or prognosis between compartments? Is it especially effective with the compartment?
Okay, the question is, will you do better if you replace one compartment or the other in a knee?
More specifically, medial compartment, it works really well for.
Yeah, you know, it actually works well, I think, for all 3 compartments. But the ones that actually tend to do the best are the technically most difficult ones, which are the lateral compartment. So people that have isolated lateral compartment arthritis generally do the best with these. Though technically, because of the kneecap and trying to get it out of the way for the surgeon, it's a little bit more difficult. But clinically, they tend to do great.
And then also 1 versus 3 compartments.
One does better. Yeah. If you do 2 compartments, it's a bigger surgery. It takes longer. I mean, I can do a total knee a lot quicker than I can do a bicompartmental partial. So you're under surgery. People do well. The right person does well. But I'll tell you, I think long and hard when I think about doing a bicompartmental, based on the conformity, range of motion, all that other stuff, about just doing a total.
That
But I've done a lot of buys, yes.
I might have missed this. If you only do one or two compartments, do you then have to do a total knee after that, or can you go in and do it in the third compartment?
You know, no. What you do is if you do two compartments and someone continues to have pain because of either progression of arthritis in that third compartment, I'll put it this way. If I went in and did a third compartment and I was taking my board exams, I would fail my boards. So the correct answer is to do a complete replacement. And that's what most people would do. Having said that, I've seen patients in my office who have had one compartment done and then 2 years later had pain in the other compartment, so they probably should have had a total to begin with, and that surgeon went and did a partial in that lateral compartment. But that's really kind of bad on the fringe. You know, really, if you have two or one that's failed, you really need to do a total.
You have a second question?
Sure, as many as you wish.
The determinants of mapping ahead of time, is there anything with this machine that will help me do it before as opposed to during in the mapping of what it is you are going to do?
All the mapping, not all, but most of the mapping is done before surgery. So even before the patient comes into the room.
I understand.
And so that mapping on the CT scans is already done. So even before surgery, I've gone over the studies and I go over them. There's always a rep from the company there. You know, we go over it and make sure that we both like it because they're very educated and very helpful as well. And then really the final mapping we do during surgery is we map the bone out. We have little probes that we put on the cartilage in the bone so the robot will know where the femur and tibia is. And then the most important thing is putting it through the range of motion to make sure that based on our preoperative plans, it's not too loose or too tight. And if it is, then right there in surgery, for example, I'll have the femur up on the computer, and I can adjust it on the computer, and then that graph tells me if my tension in the soft tissues is where I want it. And I can manipulate the femur and the tibia or both to get it just right. And then we lock it in, and then that's how the robot will cut the bone.
Thanks.
Yes.
With regards to prevention, you know, when you see a lot of people, what can we do as people to prevent injuries like this?
You know, prevention is kind of the key for a lot of things we do with ACL injuries, etc. You know, maintaining good strength around the joint is important. Maintaining appropriate body weight so you don't put too much. Even nutrition, you know, I'm not a nutritionalist, so I can tell you exactly what to take, but that's also helpful as well. And staying fit. So other than that, a lot of the arthritis I see is post-traumatic, meaning that someone's fallen and fractured their tibia, they've had a previous ACL reconstruction. So once you've had trauma to your knee, then it's kind of hard to prevent it with time. And not everybody that has trauma is going to develop what we call post-traumatic arthritis, but a lot of people will. So, you know, as far as prevention, I don't have a great answer, but it's just, you know, take care of your body. Don't comply by the fourth law of movement. I don't know if you saw that. Yes.
I have
Yeah, you know, I mean, there's plenty of data to suggest that even preoperative physical therapy is helpful and it helps people post-op. So to maximize your motion, to maximize the strength, you know, we're not going to be good for ACL, so you're still going to be unstable. Yeah, absolutely. You know, preoperative therapy is very important. It makes your post-op recovery a little easier too. The more motion, the more strength you have, the easier it's going to be afterwards.
do both knees at one time.
Again, I've done a lot of those. I personally don't like doing it, but we do it. Patients want it. They don't want to come back. You know. But you know, I tell you, a lot of that depends on what we call comorbidities. You know, if someone's obese or they have diabetes, heart disease, lung problems, they're not going to tolerate the trauma of having two knees done at one time. And and they're not going to tolerate being under anesthesia that long. So in those individuals, I really highly recommend staging it, doing one, and then back 6 weeks later, for example, and doing the other one. There's a much higher risk of needing blood transfusions if you do 2 at one time as well. I can't remember the last time we had to transfuse somebody that had just one total knee. But having said that, that's what we told us. If someone has 2 knees that just need one compartment done, they'll tolerate that one. There's a lot less trauma in those that they so they'll tolerate 2 partials at some time. All right, guys. Well, thank you so much. I appreciate you guys coming out.